Good morning, good afternoon, or good evening. Thank you very much for joining this breakout session on tracking COVID-19 vaccination, public health, and social measures. The rollout of COVID-19 vaccines has been one of the most challenging issues in response to the pandemic, and we are constantly surrounded by daily news on how many doses were administered and emergency use authorization of vaccine candidates. But the field behind vaccination is much broader than just efficacy and dosing. It includes vaccine development, manufacturing, distribution, administration, and as well as financing policies and many more. So, for example, the Biden administration in the US just announced yesterday that Merck will partner with Johnson & Johnson to produce doses of the recently approved Johnson & Johnson vaccines, which he called an historic partnership in the pharmaceutical industry. On the other side of the Atlantic, the AstraZeneca vaccine was approved by the French authorities for administration in the age group of 65 to 75 years, against the backdrop of controversy across Europe if this vaccine should be recommended above the age of 65 years. While Nigeria, the country, was one of the first countries to receive their COVID vaccine doses through COVAX. So this breakout session will discuss how PHSM trackers can collect data on vaccine-related policies and programs, and will specifically cover the needs for vaccination policy data. We will review current vaccine data collection efforts across trackers and discuss such efforts with stakeholders and other attendees. And additionally, we will discuss how PHSM vaccination data can be used to inform vaccine-related public health research, policy, and other areas. Examples of applications will be presented, and we will solicit feedback from stakeholders and researchers on what information about vaccination is most useful. This session is organized in two major parts. For the first half, we will have a presentation by our speaker, Dr. Bonnie Sweenor, and the second half will be a moderated discussion with input from participating trackers and members of the audience. So let me now introduce to you our speaker, Dr. Bonnie Sweenor. Dr. Sweenor is the director of the Johns Hopkins Disability Health Research Center and holds an appointment as Associate Professor of Ophthalmology at the Wilmer Eye Institute at Johns Hopkins Medicine. She also holds a joint appointment in the Department of Epidemiology at Johns Hopkins Bloomberg School of Public Health, where she's a core faculty member of the Johns Hopkins Center for Aging and Health. Dr. Sweenor received her Master's of Public Health and doctorate degrees in epidemiology from the Johns Hopkins Bloomberg School of Public Health, and she completed her postdoctoral research fellowship at the National Institute on Aging prior to joining the Wilmer Eye Institute. Dr. Sweenor's research is at the intersection of aging and ophthalmology and aims to improve the health of people with disabilities, including visual impairments, and is fueled by her personal experience. Together with her research group, she concentrates on vision and aging, access to care, and disability inclusion. Most recently, she has spearheaded the launch of the COVID-19 vaccine prioritization dashboard to decipher how state policies have and have not prioritized the needs of people with disabilities and vaccination plans. Everybody, please join me now in welcoming Dr. Bonnie Sweenor.
Thank you. Can I share my screen?
Yeah, that should be possible. I am not fully sure who's the host of this meeting. Yeah, great.
You can see. Yeah, we're good. Okay. Well, thank you so much. I'm grateful for this opportunity to be presenting at this conference. As Alex indicated, and we'll be talking about the use of public health and social measures to maximize. And I admit I am always thinking through a lens of equity, so there will be a heavy tilt towards that in what I'm going to present today. So to maximize equity in the COVID-19 vaccine policy or rollout, and use this example case of our tracker for people with disabilities. I'm not going to go through this. Alex did a wonderful job introducing me. So COVID-19 surveillance data from my epidemiologic perspective certainly is focused on identifying at-risk groups, individuals at greatest risk of mortality or severe illness. And at the beginning of the vaccine rollout, that evidence was largely used in developing the vaccine prioritization policies. I'm guessing most people in this virtual room understand that. But as that policy has moved forward, at least in the United States and certainly in other countries, there's been an overlay of equity in that approach. Again, I know there's another breakout room on equity. It's hard to really separate those two things. But the question is, what if surveillance data do not exist or are limited for certain groups, such as people with disabilities? How is that impacting that vaccine policy or the prioritization? The lack of data doesn't always mean the lack of risk. And what does that mean for vaccine prioritization? And I'll talk a little bit about that for the disability community. Additionally, traditional epidemiologic surveillance data doesn't always illuminate inequities, particularly if we're talking about societal, contextual, or structural inequities in certain groups. And much of the COVID-19 data, I think the reason why we are all in this virtual room, don't include those contextual measures or policy information, which may be really important in understanding the long-term impacts or in improving the vaccine prioritization policies. So as this test case, I'm going to focus on our tracker. To level set or give a background, I'm going to just briefly talk about the disability inequities that have been magnified by COVID-19 in the United States. I'll go through our tracker, our dashboard for people with disabilities, and then discuss potential impact of vaccine policy trackers or dashboards. So disability, I talk about disability enough. I know that people take that word to mean all sorts of different things, depending on where you live, your background, your experience with it. But worldwide, there's about 1 billion people that have a disability. That's recent data from the WHO. Those prevalence estimates I'm showing on this slide do vary based on how we ask questions to assess disability, and they vary between high, middle, and low income countries. But in general, you can conceive of disability as a physical, sensory, cognitive, intellectual disability, as well as a mental health or chronic condition. So any condition or impairment that impacts daily life. It really is a broad and umbrella term. The COVID-19 pandemic certainly has created or magnified inequities that really are persistent and longstanding for the disability community. And therefore, the pandemic response has been unequal and, quite honestly, inequitable for this community, although that certainly doesn't, in my mind, get enough discussion. So to understand why this matters for vaccines, the vaccine rollout, I think it's important to understand the start of the pandemic. There were gaps in accessibility at the very beginning when we were talking about testing, as well as information, and it still holds today in the US and other places. There's inaccessibility of COVID-19 information. Content information is not accessible to all members of our community, particularly individuals with disabilities. That has implications for how do you know where and when and how to get a vaccine. There's barriers at the start of the pandemic in getting a COVID-19 test and getting to healthcare sites. We're seeing the same thing happen for vaccine allocation, getting to sites and communicating, for example, in those vaccine sites. And there's greater impact of the social measures being applied during the pandemic for people of the disability community. An example I'll give is that I hear a lot about if you're an individual who's blind and you need to go to the grocery store, you may not be able to tell if those around you have a mask on. Even if you are doing, quote unquote, all the right things and wearing a mask, you may not be able to protect yourself in the same ways as other individuals in the community. There's also very limited data. And so starting with my point of why all of this tracking matters for vaccine policy, the information that we do have for the disability community has largely focused on a subset of the disability community, those in congregate care or nursing home communities, our home settings. Those are enumerated or samples that we have good data on, but that's a fraction of people with disabilities in the United States or in other countries. It's even smaller. And so we don't have good understanding of the impact of COVID on people with disabilities. And in the United States, we particularly do a poor job of collecting information on disability when you are getting a COVID test, getting a COVID vaccine. We don't understand the rates of hesitancy or differential vaccine rates, even if you are prioritized. And because of all these gaps and inequities, the impact of the pandemic response is differential. It certainly is different for the disability community. It is a reflection of societal inequities for people with disabilities that have persisted before the COVID-19 pandemic. But if we do not consider this, particularly in the rollout of the vaccine, this has implications for all of us. And, I think these are lessons we are relearning as public health professionals in this moment. The health of an individual impacts the health of the community. And we need to consider this aspect in the pandemic response. So those inequities have persisted, and from our frame have been an important driver of why we decided to create this dashboard, right? We wanted to understand how the COVID-19 vaccine prioritization policies may be mirroring or carrying forward those inequities for the disability community. And really our goal here was if we could track those policies within the United States, so each state has different prioritization. I know this is an international audience, for who's going to be prioritized for the vaccine for people with disabilities. And if we could at least compile that information in one place, and in addition, we're making it accessible. So the dashboard we have is screen reader compatible. So people with all different types of disabilities that may use accessibility tools can access that content, that information. I'll talk more about that in a minute. To allow individuals to compare and contrast stakeholders, differences in the prioritization policy across states for this group. Our goal really, again, is through a lens of equity, but it's tracking that policy in order to achieve and advance equity for this population. So our tracker really focuses on these 4 groups, and we are looking at US states and territories at this time. These are 4 groups that we chose because these are 4 groups that have implications or really are focal for the disability community. So individuals living in long-term settings, or long-term care settings, such as nursing homes. And then there's another prioritization category in the United States, which includes individuals living in other type of congregate care settings, such as group homes. That's different than a long-term care setting. People with chronic conditions. This is a broad group, but we're collecting the data with as much detail as the state will provide. And then another category called additional disability related groups, including people that receive direct support care, so someone coming into their home for care, people with intellectual or developmental disabilities. So in the United States, the CDC has specifically called out that group of individuals with disabilities because there is some evidence and data being collected for that group. So we look at them separately. And then recipients of certain Medicaid programs. So Medicaid is a federal program to provide insurance for people and other federal supports for people with disabilities. So what we do, the methodology, is we collect data. We basically scrape data from the state and territory health department websites on a weekly basis. When we did this, we did sort of data checks in a differential way, in a more thorough way, but now we do a random sample of a double data entry and data abstraction. And on our tracker, we include the sources so that individuals can link back and look with more detail if they want to find more information. We prioritized accessibility of information, and this has been important to us because what we found is that a lot of the state websites are not accessible. I think this is important for policy at this intersection. And what I mean by this is a lot of states in the US are sharing this information, for example, in a figure. So if you're blind and using a screen reader, there's no alt text on that figure. So if you're using a screen reader, it will just say image, 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 and it won't tell you the prioritization scheme. So you have no way of knowing if you're prioritized, what the priority is, and it's a huge gap in the policy in the understanding of the policy. So our dashboard is trying to circumvent that and help people get the content and the information. In addition, we provide our dashboard in a variety of formats so that people can interact with it in different ways. That's a key to providing accessible content. This is a snapshot of one of those ways of interacting with the content. This is outdated now. We just released an update this morning, I admit. And this is from one state, just to give an idea of the kind of information. We're just showing what phase the state is in, what phase those categories we're interested in are in, and then some definitions for each state, which vary. This is just a partial snapshot. It then goes on to show a link to that state. So this is a fairly new dashboard, I admit. We just launched about a month ago, not quite, February 8th. And I've been really surprised by the response. So less than 24 hours later, after response, the US National Council on Disability, which is actually a federal agency that advises the US President's Office on Disability Policy, cited our dashboard in a petition to the National Governors Association, so that's the Association of Governors across the United States, to reprioritize vaccinations for people with disabilities. So they really used our dashboard in support to upweighting the prioritization. They scoured this. I had no idea how they knew it was released so quickly after we released it, and use this as evidence that there was a large discrepancy in how states were prioritizing this group. We've also seen it being used by local, state, and national advocacy groups across the US. It honestly has, I can't keep up with the list, I admit, and we're getting well over 1,000 visits to our dashboard per day. So again, our intent here was to track the policy for a group that really has been inequitably impacted, to enable this group to an opportunity to perhaps have a more equitable response in the vaccine prioritization rollout. We prioritized accessibility. We see that actually as a gap at this intersection of public health and policy. No one really seemed to be paying attention to that until, we launched this tracker. Now there's been some news stories around that, as well as an opportunity to advocate for the collection of disability data. By tracking the policy, we've really been able to elevate this gap in disability data in general at the time of COVID and even beyond. And to me, one of the more important components here is what we found in tracking the policy across states is we get questions all the time around, what state is doing the best with vaccine policy for this community. It's a hard question to answer at this moment, but our response really has been, it's clear to us that the states that have truly partnered with people with disabilities, with the disability community, and have connected with those groups and considered their needs, circumstances, and inequities, to us really have done the best job. And that's what I think is needed for a lot of groups in this complicated and complex time and situation. And so with closing, I just want to say that, again, it was so hard for me to think about this talk in separation from the other room thinking about equity. But in my mind, the opportunity to track the public health and social measures around vaccine policy really is an opportunity to advance equity during this time and even beyond. But it has to start with partnering with the communities to determine what data to collect, how to collect it, and how to share that information to empower the communities, to empower the stakeholders with this policy information to perhaps make change. And with that, I just want to share our website, which includes the dashboard. You can find us on Twitter, and great thanks to Sabrina Epstein, who's an outstanding undergraduate whose idea was to build this tracker. Thanks so much.
Yeah, thank you very much for the great presentation. I think there's a lot of things that are really applicable to the general collection of vaccination data. And what I really also liked about this presentation is that it was focused on a subgroup or subpopulation that usually doesn't get that much attention. But I think there's still many things that we can apply to similar issues and other subpopulation groups across the globe. So now I would like to start with addressing any questions or discussion points from the audience. So there's nothing in the chat right now. People can feel free to speak up if there are any questions or comments. Please go ahead. Yeah, I'll keep on monitoring the chat. I think I'll just go ahead and start with a few questions that I had, or I think that our tracker also had, and I think that might be of interest to the general tracking community. As you mentioned, the COVID-19 pandemic has brought to light many issues related to health equity and disparities in health and social outcomes. So health equity is a global issue. So this presentation was focused on the US, but there's no reason to doubt that this will be different in other contexts, or substantially different at least. So it requires global action, collaboration. So I think the question then becomes, and I think that's also probably something that you might have been thinking about and started to address, given that your tracker is recently new, or fairly new, but how do we incorporate this into research efforts? But then also, and you mentioned that, I think that's really exciting to hear that there's this impact, or quite immediate impact, on the policy making or decision making scale. How can we incorporate this? So I know there's global issues like with vaccine distribution, but also prioritization. There's also massive lack of clarity, especially since there's different vaccines, and we don't have to go deep into immunology. I just know from like personal conversations with my friends and family, people just don't quite understand the differences sometimes. So yeah, how can we address this better? Because I mean, as the trackers, we are primarily, as you suggested, providing the data in first place. Any thoughts on that?
Yeah, no, I think that's a really good question, right? You know, as a public health professional, I think in this moment, right, there's a lot of thought around communication and partnering with the community, which is, you know, how I ended, because that's ultimately our true test at this time, right? The research is so important, is critical, but is just the start. The end is getting the message out, right? Is communicating with the community members, with stakeholders in ways that matter. And that, I think, hasn't always been prioritized enough. And so in my mind, building these dashboards and these trackers have been an opportunity to do just that, right? And you know, if there's opportunities to continue to enhance and build on that moving forward, in understanding, you know, how people are responding to, you know, questions around differences in the vaccines, or, you know, to your point, I think we should try and understand that, right? But we should make sure that we are sharing information back to the community in tangible ways, in accessible ways, and not just keep it amongst ourselves as researchers. And I think, to me, that's what these dashboards and these trackers are really about, right? It's sharing, disseminating information, so that everyone has a chance to be a part of this process. You know, your other point about research is, you know, one I think about all the time. I'm first and foremost, right, a researcher, and you know, I have lots of thoughts about that. You know, why are there such differences in the prioritization across states? Really, like, really, why, and what does that mean? And those are the kinds of questions we're thinking about. And they can be broad questions. So the things we're thinking about is, you know, we just had a big presidential election in the United States. And I know this is very US specific, and I'll talk a little more internationally in a second. But in this US election, there was the biggest turnout of voters with disabilities, but that varied by states. And so, you know, that matters because you're putting people into to the places of power that now get to make the kinds of decisions around things that impact the prioritization at a state level, right? Or even at a federal level. And so is there a relationship between voter turnout for people with disabilities and how they're being prioritized? So, you know, what's the relationship between the democratic process in the United States and these decisions, right? I would love to know that. And, what's the difference in long-term? Does it, in the end, I think we all have ideas around if this all really matters, if you get vaccinated 2 months earlier or not. And certainly it does for those individuals that, unfortunately have in those 2 months have a bad COVID outcome. But, long-term health-wise and societal-wise and income-wise and all of those compounding factors, we really need to understand what is the true impact of the differences in prioritization, right? And then I think, at an international level, and these are data I don't have or know, and not just for disability, but for other groups, just trying to better get a handle on the differences in these policies, around the world, and understanding, again, I think the long-term impacts, right? We live in a world where we are all connected. It's not so finite. And so the prioritization is different. And the way that the policy in some countries, as you were alluding in the start of this, they're adopting different policies. And how is that affecting within a country, but also between countries? I think that's to be determined. But we need to understand this now, right? Because this is not going to be, unfortunately, the only time we're in this situation.
I totally agree. And I think this is not necessarily specific to infectious diseases or pandemics. There will be similar issues with access to care, such as screening for chronic diseases, for example. One follow-up question I had, since you mentioned surveillance all the way in the beginning, and it's kind of how I started getting into public health. What are your recommendations on that? Because I think one thing that COVID has shown us is that surveillance on the one hand is assumed to be a government issue or something that governments usually take care of, at least for infectious diseases. And then we had the Johns Hopkins mapping tool stepping up to that need because apparently it didn't work. And from what I know, working in the area and doing some research, you're certainly right that data we collect, especially on additional indicators, is kind of scarce. I think most countries don't even have data beyond age and gender, if so. How can we address that? So because obviously there's different paths. We could say, well, we keep on doing this as academic institutions or nonprofits and take on that job. Or how can we make a good case for governments to look more into this? Because that's really systematic. Surveillance is something that needs to be built as a capacity. It's not usually the case that you can easily step it up because it's such a broad and complex system.
Yeah, I think that's a really important question right now, right? And I do think probably it's a time to re-examine that old way of doing things, right? We saw it fail, right, more or less. And to your point, when I've given these kinds of talks in the past year, I usually end with something like, we need to not just think about the data we have, but the data we don't have. And not just because of what that means for our statistical inferences, but what that means for social justice reasons and equity, right? Who's present and who's not. And there's more reasons than sample size and power, right, to think about that. And I think, I don't have the right answer to that question, but I think that's exactly the right question right now, is who is, the vanguard, who should be in charge of these efforts? And perhaps, it shouldn't just be one entity. Perhaps it should be a shared responsibility because it is so important, right? Maybe it shouldn't just be the federal government. It should be some partnerships so that if one system is failing or there's something like we have experienced in our country, the United States, that, we have another group or arm or support system to move that surveillance forward. So to me, that's one component, is to reimagine that. The other component, again, I keep speaking to this, is making sure we are partnering with the community, right? Surveillance is built on surveilling the population. And I do also think it is time to do better on who we value as part of our population and understand that data are powerful, right? And it is a tool that can make big change. And I speak about this a lot for the disability community. There's lots of reasons disability is not included in surveillance, and it is a direct reflection of how we think about disability in our community as lesser, as not important, as not to be included, right? But the problem is because we don't have the data, we don't have the opportunity to understand inequities, to understand risk in the population. And so for many people, many groups that are evidence-based, it appears that there is no problem. And that's simply not true. We just don't have the data, right? And so that's how I started out. Lack of data does not mean lack of risk in all cases, and sometimes in many cases. And so we have to unpack that and think about that. I think in this moment, this is really, in my mind, a shift for public health to overlay equity across all the things we're doing, right? And that comes from partnering with communities, bringing them to the table to think about how and who we are including in our surveillance efforts. That's my hope moving forward. And I know that is also a monumental task and is not going to be easy. And how do you do that, let alone within a country, as well as around the world? Because we also have to think, not country centric, but how then would we do that low, middle, and high income settings, right? And that's critical.
Yeah, I totally agree. Those are some very valuable key insights. Do you have any ideas on how to include the community more? Because I think that's something that this pandemic has shown us, not only for people living with disabilities, but also in the US, racial equity has been a huge topic. And both from my experience and also just from the general experience living in this country right now, there's a lot of researchers that say both surveillance, but also more modern issues like modeling, we need to somehow integrate the voices of the community to actually target our data collection and our modeling and our outputs towards what they need. Because the common experience, at least in this country, and I think many countries across the globe, even if you do research, so if you try to establish an evidence base, oftentimes you end up collecting or analyzing something that doesn't really fit the need or targets the demand of the population that it's actually tended to impact. And I really like that example that you mentioned about the visualization, because everybody's so much into mapping and like graphing and I don't know, fancy Tableau dashboards right now. But then as you said, for people with visual impairment, that's kind of useless if you don't provide an explanation, because pictures, it's obviously difficult if you can't see them. So maybe just a few thoughts on how we could improve that, especially given that for me at least, my perception is the tendency is kind of somewhat against that, where we do just a lot of stuff just in terms of let's do research and get something out there because it's a hot topic, and then it doesn't work, and we just ask ourselves, why is this not happening? Like, why do we not have the impact? And then somebody from the community finally stands up and says, well, this is not really what interests us or what even affects us.
Yeah, absolutely. Again, I think a really important thing to think about, particularly at this moment, right? And I think as public health professionals, and I got my graduate training a number of years ago, but it's certainly not something we're trained to do, right? And in my mind, that has to be part of the shift, is it has to be built into our public health education. Going through this pandemic, at least for me, has highlighted how we've really moved away as public health professionals from our underpinning of social justice work. I mean, truly, public health is built on a core value of social justice. But to your point, it has very much moved into, in many places, a very academic pursuit, right? And there's good reason, and there's been great innovation because of that. But I do think we need to always make sure we're getting back to the why are we doing this, right? Why are we doing all of this, and who are we doing this for? I think, to your other point, there's also certainly challenges in a lot of research careers around just being successful as a researcher that are, structural, that maybe are bigger than this discussion, but I think probably need to be reconsidered. But I don't think a lot of us are trained in broad ways of how to partner with communities, and that should be the underpinning of what we're doing. And that probably does need to change, whether it's, modeling, I think a lot of people that's not obvious that needs to be done in partnership with a community or in consideration of, right? And it shouldn't be, but at this moment, I think a lot of people don't think about that, right? There also probably does need to be better efforts to connect with communities and create that conduit, right? Where do you go to connect with wherever you are in the world? Who's your stakeholder that you're connecting with? Who is the spokesperson or the group of spokespeople for the community that you care about or you're studying? And the thing that also layers complexity on, I care about the disability community, that's what I study, but you can't ignore, racial, ethnicity, gender identity, age, it all intersects. And I think we are getting to this place in time where we need to honor that, understand that, realize that. And so it's not just one stakeholder group, and that will perpetuate the problem, right? It has to be a compendium, a group of voices. And I don't know that as public health professionals, we spend time or have dedicated individuals always in our collaborator lists focused on building those connections up. And I think that's part of the problem.
Great. Yeah, I totally agree. Yeah, I think I've been going on for quite a bit. I would maybe open it up to the audience right now if there's any questions that members of the audience would like to ask or discuss, or also with regards to broader issues just in general, vaccine policy coding, because it's such an emerging topic and it's such a timely topic. So we probably have to think about that. But also I think some of these points we just discussed with inequities or like more specific populations, this is really important, or will be very important in going forward, because I think in many countries the prioritization framework and also process has not been smooth. So are there any questions or comments right now that we can address?
So while people are thinking, I think another thing to think about that I get questions a lot about are, how do you prove you're in a priority group, right? That's another consideration, and we're not really sure. We've discussed it amongst our own dashboard group of how to track that, and it's hard because there's not a lot of written policy yet around that, but this is a big concern, and I don't know that we have a good handle on that. For the disability community and other groups, it's complicated. A lot of states in the US are operating under an honor system, which, there's pluses and minuses to that. I don't have a good response there, but I think that's something to think about, right? Is if you're going to, the double-edged sword of if you're going to take a high value on an equitable rollout, there's probably a lot of complexity to it. And we've seen states with really complex prioritization plans. But then the question is, how are you ensuring that, you're not getting a quote unquote healthy 20-year-old that would be at the end of the line show up and say they have a disability? That there's a lot of social issues around questioning individuals with disabilities that we combat against as as a center, as a group, that is complicated. But how do we do this? I'm not sure I have an answer, and I'm not sure if others have thought about these things, whether it's disability or any other group. But how are you ensuring that the prioritization is being held, and the logistics of that? right, is still to be determined. And then, in this work, I'm always trying to think about, we're at COVID-19 now, but how can this information, how can this be a lesson learned moving forward for other situations? And any sort of scarce resource public health emergency, you can imagine, hopefully we are learning lessons that we can apply to do better at. And there certainly have been historical examples of scarce resource situations where, allocating food or other important aspects of life to certain groups. And there's been challenge in that. So I don't know if others have thoughts around that.
Yeah, we definitely welcome contributions from the audience, but I agree. I think that's also something that the US specifically encountered with this idea of prioritizing comorbidities, and then people started getting into the issue, which comorbidities, so which health conditions actually, not necessarily only disabilities, but just things like heart issues or cardiovascular disease. And so how, and then maybe how many, and actually how do you track that? And I think then, and early on, I remember in the pandemic, there was also a lot of discussion among ethicists here that this, which has become mainstay right now, this age-based cutoff itself is not fair, because in the US and many other countries globally, people with a certain racial background or minority background or migrant background have a different life expectancy. So once you start prioritizing people above 80, usually you target a very specific subpopulation that tends to be advantaged because of the ways they live, but also the context they live in. So I think that's something that we try to consider, but then, as you mentioned, the process behind it, the system was just too complex. People started thinking, how do we actually find out who has which comorbidity? And also, how do we define it? I think that was a major issue, especially since everything was kind of stamped up really rapidly. And this is not only specific to the US. So I also know that, for example, in Germany, there were many lawsuits about people trying to get access to vaccines because they had underlying conditions such as cancer. And the government just strictly tried to prioritize age as the major factor. And I think this just goes on, as you said, it's the intersection. You can also ask the same question about occupations. Who do you prioritize, and then why? I mean, yeah, sure, there's healthcare workers, but then there's been an ongoing discussions about, should we start vaccinating teachers earlier? Why are teachers not like other frontline workers? And so I think that's certainly something that we will have to figure out moving forward. But I also appreciate that you mentioned that it's actually possible, because I think many, like especially humanitarian emergencies, showed us that it is possible to target certain populations that are historically disadvantaged. There's ways to do that. We're just not doing it right now. At least I think most countries are not.
No, you're right. And in fact, on our tracker in the last, not with this update, but with the last week, we saw 2 states slide back into age prioritization, which was unfortunate. And, there's been a lot of backlash around that in the United States. And it is concerning, but the response from those states was, this is too challenging. We can't logistically manage the complex prioritization schemes. And, I actually was asked to make some comments in the media about it. And I think, it's hard. And, I think being a public health professional and having colleagues and friends and being on all sides of this equation, I think a lot of us are doing the best we can here at this time, and it's a monumental task. But because it is complex, doesn't mean we back away from trying to achieve equity. And that's, to me, a hard line, right? And it's complicated. It is. It's really complicated, but I don't think we turn our backs to it because it's a challenge. That's where I think, the partnerships and the discussions have to happen. And we recognize we're not always going to get it right, but this is an opportunity to learn and to work hard to understand in this moment how we can do better moving forward. And document it, right? And that's why I think the beauty of these trackers is documenting in real time what's going on. And so on the back end is an opportunity to really understand, you know, the differences in the policies, and then to study what impact those differences had, right?
No, I totally agree. I think that's exactly why we do need this data, and where it will become valuable, especially going forward. Yeah. Let me just check if there's any additions from the audience or questions. Yeah. So maybe.
Sorry, I think someone has their hand up. I think that's what that is. Is that right?
I don't know. Oh yeah, Ola. Yeah, maybe I can. Can I unmute you? Yeah, just feel free to speak up.
Sorry, I just wanted to add to both of your points that do we prioritize those that have medical risk factors, and do we include those who have other risk factors? So you mentioned age, but do we also include things like your socioeconomic background and things like that as well? I think one real difficulty with that is that here in the UK, it's very, very easy with the NHS to see your age and get your medical background. So it's very easy to set out the priority groups and send out the letters, etc. But not a lot of them collect. There isn't like a centralized database of all of those other risk factors. So how would you go about adding those to the priority list, and how, if you do add them, how would you then communicate with those communities if it's not just from you're in this list, here is us telling you you're in this list through the media, or how do you actually go them? And I think that brings into your point of can someone just go up and say, look, I've got a disability, let me in this group? Yeah, I was just wondering what your thoughts were on that.
No, great question. You know, I think that we have the same problem in the US, right? We don't track disability in our electronic health data, nor do we really have socioeconomic status data, right? And nor do we always have complete, you know, racial data. But again, I don't think that complexity should make us back away from addressing what we know are very clear inequities and the impact of COVID, right? To me, that is, I struggle with that as a public health professional. Just because it's hard doesn't mean we don't do it. So I think that the rollout and the things we've seen in states that are doing this well they are putting out very broad calls through media, through their channels, through their stakeholder groups to say, you know, here's our prioritization scheme, right? Here's where we are, here's the groups, in very clear, good public health communication strategy. It's not that you are individually targeting a person and saying your number's up. You're saying, this is the group we're prioritizing. If you fit that group, come in. We have many states that operate under an honor code. And I think that there's good reason why that should be okay, right? I think that, to your point, it is really hard. And yes, there will be people that slip through the cracks and break the system. I think I don't have a perfect answer here, right? There's downsides to, quote unquote, proving you have a disability. Just like for socioeconomic status, what do you bring? You know, a pay stub. You know, I think there are some ways you could ask to do that. In the United States, we also have some states using affidavits saying, you know, I have a disability, and, you know, under law, you know, here's a piece of paper, I'm signing an affidavit saying I have a disability. If you want to check my records, we can do that at another time, but put the shot in my arm today. And lots of states are doing that. So you're basically signing a legal form saying I attest legally that I fit this category, right? And then on the back end, you can do a check if you so need to. But I think in this moment, it is an unusual time, right? And I think that again, I just really hesitate to back away the policy through a lens of equity. I think that's because of the complexity. I mean, that's, yeah.
Yeah, thank you. Sorry, I realize I don't have my camera on, but I was nodding away there with your points when you.
No worries. I know
but thank you for your input on that.
Yeah, I mean, this is really hard stuff, right? You know, I know it is, and it is, and I think it's a really interesting lesson to be learned, because it's not just about this moment, right? I think we can learn a lot from this time for a lot of applications. Yeah. But again, to the starting point, a lot of this is our communication, right? We need to do a better job, even just communicating and partnering with our communities.
No, I totally agree.
I think we have an example.
Go ahead.
Sorry, I was just going to say that we had an example here of those with learning disabilities are now included in the vulnerable priority group here. And that was from communication with the community. So it does work. There is evidence that this does work if you communicate with these groups. So it might be difficult, but as you say, it's not a reason not to do it.
Yeah.
Sorry, thank you, Alex, back to you.
Thank you. Great question.
Yeah, I totally agree. Great question. I also like the examples. I was just going to add, as an epidemiologist, I often thought about that it would be great if every country kind of would be like some of the Scandinavian countries, where everything goes together in a database or is tracked, and then you can link it. But I think that's another key thing. The pandemic has shown us that even these countries are not perfect. They also had major issues. So it is true. I think we really need to communicate, and also part of that is asking questions. So because that's what scientists do. We ask questions. We also try to find answers, but one of my mentors always told me that real researchers actually ask the right question. So yeah, I think, and that's front and center in communication.
I agree. And I would add, thing I say to my trainees is, who are you asking questions for, right? Are you asking questions for the research community or the community you serve, right? And I don't know that there's always a wrong there, right? I think sometimes asking questions for the research community, such as methodology, is critical and really important. But somewhere along the line, in my viewpoint, as a public health professional, we have to ultimately answer to the communities. I'll disclose in this group, I have a disability. I'm visually impaired. I've been losing my vision for 15 years. That's why I do this work. That is completely, my perspective on the pandemic. And, I see the gaps personally and professionally. And I think there's just such little, focus in public health on, I think, both including people with disabilities as researchers, which is part of the problem too, but just really understanding the nuanced ways that the things that people take for granted every day do impact certain groups very differently. And I think that's our job, is to try and understand that.
Yeah, I totally agree. I think on that point, there's been quite some discussion recently that if we want to address inequities, we also need researchers that actually understand these inequities, because they have been impacted by exactly these inequities. And that's also a huge issue with racial and ethnic minorities in the US. From some of the modeling work I've been doing, or like working with modeling stakeholders, it is really tough to find people with a Black or African American background in modeling in the US, or I think probably globally, because they just don't have the access to the education, or maybe not even the interest, because they are not being motivated, or they are not being given the chances to actually find out why modeling might be interesting for them. And I think the issue with that is, on the one hand, that is a very great goal, but it's also a great challenge, because you can't just go out as a university, as your admissions department, and try to recruit more people from a certain background because they might not even be out there. So you have to probably start way back, I think, and that will require societal change in terms of that we drive towards equity and equal opportunities, I think, because that's something that we encountered, that sometimes you can look quite hard and you can't even find people because it's way earlier. For example, with modeling or this kind of research, if you don't really understand mathematics because you were never encouraged to get into mathematics, the likelihood that you will pursue a graduate degree in biostatistics or modeling is very low. So I think that's why it's important to ask communities, but also very early on. And I think,
No, I agree completely. But from my, stance, this is also interconnected, right? I think the power we hold in the positions we have doing this work is to change that paradigm, right? To partner with the communities, to change the way individuals are viewed and internalize that view. I think it's also related, from my viewpoint, right? And I give an example of, I looked at some data once about the career success of women in science. And, it was me and two of my friends were talking about this data. And one, was a white woman, and she said, maybe things are getting better. And my other colleague was a Black woman, and she's like, no, but look, for Black women, it's not changing at all. And for me, I said, women with disabilities aren't even on this map. Like, data aren't even collected. And so the point being is we bring our own perspectives, right? Of course, to the same data. We have a slightly different interpretation of the exact same data, and that's what matters, right? And that's why the community perspectives matter. And so to your point, Alex, right, it's not just about having the community members in the community, but having the community members on the team. But I also think that this work has so much bigger potential than vaccines, right? It has potential to change the world, the society, the way, these groups, the way that we think about people in our community. And to me, that is one of the more exciting parts of this kind of research.
Yeah, I couldn't agree more. And I think that's a really great closing statement, because it highlights the value of all this beyond just focusing on vaccines or medical implementations. So yeah, with that, I think we can conclude the session. As just mentioned in the chat, the conference, so the larger conference, will continue in the original Zoom room. I think there's a break right now from what I understand. So, but please feel free to already join back in the room so you're on there. And then the next session, our final session of this day, will be in 15 minutes, so 5:45 Central European time, which is the equivalent, So thanks again for joining the session, and thank you also for your contribution, Dr. Sweenor, and have a great day.
Thanks, everybody. Thanks for having me. Bye.
Bye-bye.